Good morning. Thank you, Sarah. My name's Tammy Soukup. I work at the VA Medical Center in Milwaukee, Wisconsin in the neurology clinic. And the presentation today was done while obtaining my master's degree. My thesis focused on Alzheimer's disease, dementia, and mild cognitive impairment. In addition to working in the neurology clinic, I am currently used as a consultant throughout the hospital, helping the units, not only the nurses, but the interdisciplinary team members and the caregivers for dealing with their loved ones when they have these difficult, challenging behaviors. So I'm excited to share my information with you this morning. So we're talking about promoting safe patient care, improving communication for ALS.
You can go ahead.
Oh, okay. So at the completion of this little presentation, you'll be able to define dementia, describe personhood and how it affects caring for patients with ALS and dementia. And what I'm going to do is introduce a framework, and this framework has been shown to effectively communicate with patients that have dementia or mild cognitive impairment. Why is communication important? Many, many reasons. First, there are an increase in ALS patients that have dementia or mild cognitive impairment. This is a new area that is going to be looked at further with more information. Within the last 10 years, the diagnoses were separate. It was dementia and it was ALS, and there was no communication between the two. 50% of ALS patients now have MCI, and 20% do have dementia, usually frontal temporal dementia. So this is the part I'm going to be focusing in on. And as much as 90% of our communication takes place through nonverbal actions, facial expressions, gestures, touch, all that is very important. So first of all, what is dementia? It's defined as multiple cognitive deficits that include memory impairment and at least one of the following cognitive disturbances. Aphasia, that's where they have decreased language function, and this you'll see a lot of in frontal temporal dementia with our ALS patients. Agnosia is where a person cannot even identify everyday objects. This is another area that the ALS patients can be affected with. You can hold up for instance, a pencil, and they'll look at it and they'll say, oh, I know what it is, but they can't get the word pencil out. Very frustrating, not only for the patient, but also for the carers. And apraxia, and they have a decreased ability to perform motor functions. This is another area that seems to be affected by frontotemporal dementia. For example, you ask them to brush their teeth and they just can't seem to get the sequence going. They can't do it. So to be considered for dementia, the cognitive deficits must involve a problem in occupational or social functioning. The patient's behavior must be a decline from previous level of functioning. And a required behavior to make the diagnosis is memory impairment. And this is where in our clinic we have neuropsych testing. People come and help with the evaluation process. We all work together. So there are many signs of frontal temporal dementia, and it can be very frustrating for the caregivers. There's a change in language, a change in behavior. There's wandering, they'll pace back and forth, back and forth. They're confused, inattention to personal care, mood swings. They can be mad, next minute they can be crying. They can be very fearful. They can't problem solve, and they have poor communication. The behavior can be very impulsive. They can't, like I said, sequence things. This is the old culture dementia. This is the type of dementia when I went through nursing school that I knew. These patients were sedated and medicated. Everyone worked off a medical model. Care was based around institutionalized schedule. It was 8 o'clock, they got their meds. 8:15, they had their bath. It was according to the nurse's schedule only. And getting the job done was the most important thing. Well, things have changed. Research has shown that there's a new culture of dementia. The big thing is getting to know the patient and to provide them with their personal conversation. And it's to know their personhood. It's person-centered care. It focuses on the unique qualities of each individual, and it's focused on creating empowering environments. And I think with our ALS patients, it's really unique because we do really get to know the patients. We get to know what their past history was, what they did for an occupation, what their life was before they were affected with this deadly disease. That's what knowing what the personhood is. And even when these patients do come to the hospital, patients with dementia are more confused in a hospital setting, no matter what. So even with patients that have ALS and the frontal temporal dementia, you bring them into the clinic setting, routines are changed. They're going to be more confused. So communication is challenging. It doesn't matter if the patient's hospitalized or how qualified you feel as a nurse or part of the interdisciplinary team. And that's why we always have our neuropsych with us. It's an interdisciplinary approach. Tom Kirkwood had a model of personhood. And he stated that the personhood was unique to each individual. Each one of us has a personhood. And in addition, the patient needs to be treated with deep respect. And it can be very frustrating because these patients can just be pacing back and forth and not wanting to stop. They can be continuously rubbing their hands. It's very frustrating to get the patient to do what needs to be done. So again, the personhood is the individual person, their unique story. And it's the humanistic caring of the traits of the nurse or the caregiver. And you're focusing on the patient and not the disease. Sometimes just a touch of the shoulder or holding their hand or just sitting and listening with them makes quite a difference. And what you say is important, but how you say it is equally important. And what's interesting with these patients, they have a sense that they know they don't know what's going on, and they get very frustrated too. So for example, we're going to reframe the sentence to be positive. It's very basic, but let's say the patient is eating and putting the ice cream in the mashed potatoes. So instead of saying, don't put that ice cream in the mashed potatoes, how many times have I told you to do that? We're going to reframe the sentence. What we're going to do is focus on maybe the ice cream, for example. Oh, you like ice cream. What were your favorite flavors? Do you have memories as a childhood of eating ice cream, going to an ice cream stand? It's really interesting that these patients can remember things from the past. You can talk about the mashed potatoes. Oh, their grandmother made mashed potatoes with gravy, or they used a ricer. Some of these patients, you can get them refocused on what the memories of their past to get them past this putting the ice cream in the mashed potatoes. Here's another one. We had a patient who paced back and forth, back and forth. We couldn't get her to stop pacing. Your sister died 3 years ago. She's not coming to visit you. And that's like the last thing you want to say. Now, to use the personhood example, you're going to talk about the patient's sister. Oh, tell me about the patient's sister. What kind of memories did you have with her years ago? What did you do? Tell me the activities. You want to redirect and focus on what is going on, like with the sister. You don't want to say she's not coming back, but you want to talk about the memories in the past and get them refocused. This is the last one. You know that toothpaste goes on your teeth and not in your hair. So once again, you can focus on the teeth. Oh, you have such beautiful teeth. Tell me about your teeth. Maybe the patient was a dentist. We had one of our patients that was a dentist, and he talked about teeth. We got him refocused. Talk about the hair. Oh, you have beautiful hair. You can braid the patient's hair. You get them refocused on something else other than the activity that they're obviously not doing. So what I found while doing my research is a framework, and it's called VERA. And frameworks help nurses and carers. It's a set of principles to help guide communication. And this framework can be used, it's applicable to all interactions with patients, no matter how severe or what type of dementia that they have. And this framework has been used specifically for patients with dementia, and according to the National Institute for Health and Clinical Excellence, it recommended that these individuals with dementia should have access to personalized care as well as appropriately trained staff. And that's what we're finding, and that's what I'm finding as a consultant working on the various units, that these caregivers don't know how to appropriately care for these patients when they're acting out in these impulsive behaviors. They don't know what to do, and they get stressed, and they get burned out too. So the first part of the VERA framework is V for validation. So what you want to do is enter the emotional and personal world of that patient, their personhood. You develop an awareness of the person's feelings and the meanings of their actions. Well, are they cold? Why are they acting that way? Are they waiting for their sister to come home? Are they in pain? I mean, you do want to assess to see if they're in pain. You attempt to understand how that person is interpreting the world, what's going on with that person. And the last thing you want to do is impose your own view on that patient. The E is the emotion. This stage will focus on the emotional content of the communication process and not the unintentional verbal content. The nurse pays attention to the emotional content to ensure that meaning is extracted from the communication that is difficult to understand. There's a reason why the patient is doing that, and you want to focus on what's the cause and then refocus them. The R is for reassurance. Now, this is any verbal or nonverbal act of communication that you want to help reduce distress by demonstrating optimism and kindness. And this is offered in response to the patient's anxiety or fear, in response to psychological or physical threat. And what you really want to do is develop a trust between the nurse and the patient by showing humanistic traits. And then the last is the A, is the activity. So these patients with dementia, they still need to feel a sense of occupation and activity to maintain their personhood, according to Tom Kitwood. And what you want to do is find out what is useful or helpful to that patient. Like I said, with these patients, they had a life. They had something before they were devastated with this awful disease. They feel non-helpful, non-useful, and you want to help not only the carers, but the family connect with these patients. So once again, this framework is used to improve communication and help provide compassionate care. And it's a clear stepped approach for patients that do have dementia, and it helps rediscover that a person does exist behind this awful disease. Any questions?
Hi.
Yes.
Again, me. What happens with the patients with a fully functional dependent? Like they can only move their eyes and they're in an institution, the nurses change, they have shifts. How will the nurse identify if they have dementia or if their personhood has changed?
A lot of that has to do with the nurse-to-nurse handoff, and that specifically is what I've been working on with the various units with the nurses. You have the nurses have been having extensive training lately in dealing with these patients, and they've been taught now how to help use this framework, and they have bedside handoff, and they communicate if there is a change in the patient's cognition. So we've been training these nurses to help use this, and those examples that I gave are what I've been using with the nurses to help them refocus too. So again, it's a lot of caregiver training now with these patients with dementia and even MCI. A lot of work to be done. Okay, thank you very much.
No, there's other questions.
Oh, yes.
It's hard, just so you know, it's hard to see because that bright light is in our face.
Oh, yeah.
My question is, have you ever tried to reevaluate the patient's cognitive function? Any difference after you treating the patient with respect, asking the patient about the sister's story, and that kind of care, will that show any impact on the outcome of the patient's cognitive function?
We work with the neuropsych testing, and it just seems that there's good days and bad days, and what we have found is a lot has to do with the carers and how they're able to handle these patients, that they don't get frustrated and they're able to refocus using this framework. So it's still a work. It's still a work in progress. But we realize a lot has to do with the nurses, the interdisciplinary team members, and the family members. They need more training in how to care for these patients.
Yeah, it's great. I hope to see the quantified.
Yeah, it's exciting.
Data. Yeah, thank you.
Thank you.
I have another question. So I saw you've worked on it with the nurses. Have you moved on then to the caregivers yet at this point? Like family members?
Yes. Slowly, like I said, in our clinic, we work extensively with the families and carers with our multidisciplinary team with ALS, and also on the units too, because our clinic does have a dementia Alzheimer's clinic. I know a lot of the families, and I go to the various units and work with the nurse and the family with getting this out. So like I said, it's new and it's evolving, and there's a lot of work to be done. And what I found is there's an interest. I get consulted a lot about all different types of patient behavior throughout the hospital. Yes.
Hi, Claire Flaherty from Penn State. I just wanted to make a couple of quick comments. First of all, thank you for the presentation. It's very important that the whole team is on board with what the actual condition is. So I just noticed that when you put up the description of the dementia, you were using American Psychiatric Association criteria. It might be really helpful to take a look at some of the frontal temporal dementia specific criteria.
Yeah.
Because memory is really not a major issue for patients in the early stage. Of course, later stage, all dementias converge, so people have whole brain problems. But early stage, there are criteria for consensus. Mike Strong published something in 2012, and you would refer to that not as mild cognitive impairment, but as ALS-CI or ALS-BI.
Sure.
And it's just a slightly different criteria, with memory being relatively reserved. And the other comment I think was really great that you emphasized that it's not so much what we say, it's tone of voice. When communication starts to become compromised by language changes, it's really, and you were illustrating it really nicely, that it doesn't even matter what words you use, it's the tone, like the brainstem picks up the tone, and the words just don't matter if the tone sounds threatening. So
exactly.
that's a great point that you made.
It's exactly. Thank you.
Rebecca Axline, social worker at Houston Methodist.
Yes, hi.
Enjoyed your presentation, and I so love that you weave in the aspect of cognitive with the ALS. I too work with both Alzheimer's and ALS, and a lot of times the difficulty is when there's really soft changes that isn't necessarily even diagnosed, or there's so there's not a clear picture, but it's just so soft and changes. And I admire you empowering the carers and the other practitioners, because as you said, not only the tone of voice, but also changing, it's a whole paradigm shift. You have to change your communication, and I really try to focus with families how to do a two-step process of allowing to give themselves a moment of grief because they acknowledge the sadness that these changes are taking place, and then empowering the tools to intervene a different way.
Right.
But I think this is really wonderful to give this, these tools to this population, so
Yeah.
thank you.
Oh, thank you everyone for your comments.
Anyone else? Oh,
Joanna Harris from University of Louisville and ALS or not the ALS Association, but the clinic in Louisville. The VERA framework is
Yes.
applied specifically for patients with cognitive impairment, correct? It was developed.
Dementia.
Has it actually been applied for patients? Because it seems like it would actually benefit all patients, but has it been applied for?
It does.
Okay.
It can apply for all patients, yes.
Okay, I'd like to thank you for that
Thank you.
presentation.